So welcome everyone. As I was saying, my name is Harry Porter-Penner. I'm Executive Director at IPR. It is my pleasure to welcome you all here today, and in particular to welcome Wes and to welcome Jennifer to this discussion. Before we kick off, I'm just going to ask Chris Thomas to stand by our microphone and to just give a few seconds introduction to the Commission on Health and Prosperity which we published last week with Wes in attendance. Over to you, Chris.
Thanks, Harry. Hi everyone, hopefully you can hear me. I'm just going to give, having launched this big piece of work last week, a few bits of provocation for the conversation. So last Wednesday, Tuesday and Wednesday, and the links between our health and the economy and the policy programme that comes off the back of that. A few key findings that I'll throw in as provocation here. Firstly, that health in the UK is going badly. We're lagging comparable countries. More people in the country are sick, and we have sickness challenges at every age group, from children to adolescents to working age adults to people in retirement. Two, that's doing huge economic damage. We have 2.8 million people out of the labour market because of sickness. That number is growing. We have a productivity challenge accentuated by health, and we have less growth as a country because of the sickness that we're experiencing. So that's the prognosis. What's the solution? And the Commission has been about turning to solutions. Our argument is simply encapsulated by the idea that we have a very reactive approach to health policy today, that we too often wait for someone to fall sick and only then intervene. We argue we need a more proactive approach built around prevention. We've been very encouraged to see the green shoots of prevention coming through in the new government's agenda, but that's the way that we see health and prosperity coming together, by reaching people in the places they live, work and grow, and by bringing health outside of hospitals and clinics into places people actually spend their time. So that's the provocation we have for a new way of thinking about health. There's more on the Commission on IPPR's website, but I did just want to give a little bit of that to inform the conversation and to let you all know about the work. Thanks very much.
Thank you, Chris. Great. So this is going to be a conversation. So we're going to ask Wes some questions. And bring Jennifer in, and then we're going to open up to the audience for you guys to ask questions as well. And we've got 45 minutes, so we're gonna get going. Wes, I wanted to start. You made a very provocative statement very early on in your tenure as Secretary of State for Healthcare on the shift at DHSC to an economic department. Can you tell us what that means for you and what's changing in the way that the department's working to make that reality?
So everyone thinks about the Department for Health and Social Care as a public service delivery department. So we're responsible for the NHS and our health services, and responsible for social care. And that's absolutely true, they're accurate. But I also think of the Department of Health and Social Care as an economic growth department, because we know that the health of the nation and the health of the economy are intrinsically linked. Look at the nearly 3 million people who are off work, off sick, and unable to make a contribution, either because the NHS wasn't there for them when they needed it, or because we didn't take the bold action necessary to keep them well for longer. And it is clear whether you are listening to the nation's chief medical officer, who is there to give us advice on the health of the nation, or you are listening to our Office for Budget Responsibility, who is there to give us advice on the health of the public finances. We can't go on like this. And the NHS is an enormous risk to the future of the economy and to the future of the public finances. And so unless we take the action necessary now on both public service reform, health and care, but also public health reform, we are going to end up in the not too distant future with a country that doesn't have an NHS as we know it today, or best case scenario, an NHS with a little country attached to it. And so I'm kind of taking on two opponents of reform. In sort of broad terms, and for simplicity's sake, we'll call them the Guardian and the Daily Mail. On my right shoulder, I've got the Daily Mail saying, "Love what you're saying about NHS reform. I mean, they don't quite say it like that in the Daily, it's the Daily Mail, but they kind of agree with what they're saying on health service reform. They say drop the land state stuff. And then on my left shoulder, I've got the Guardian saying, love what you're saying on prevention. We love op-eds on the social determinants of ill health. But can you drop all this posturing on NHS reform? By the way, we hear that Alan Milburn's back and we find that terrifying because he makes you look left wing. And the Daily Mail and the Guardian are half right and half wrong. Unless we do both of those things, health service reform and public health reform, not only will we fail to deal with the crisis that we see before our eyes today, we will fail the long-term future of our country because we will not have flattened the curve of cost and demand that threatens to bankrupt the NHS and leave people without the equitable principles and the promise of an NHS there for you when you need it, which we built in 1948. And I'm an optimist, so I do not believe that something that could be built in 1948, in the aftermath of the Second World War, to service in the 20th century is somehow now unaffordable and unsustainable in the 21st century. I came of age at a time when people were singing things can only get better. It was true then, and it is true today.
Sitting where you are now, earlier today was Liz Kendall, and she said she agreed with the discussion around the idea that DWP needs to be a health department as well as a work department. How are you going to get your colleagues across government to take health seriously and to drive the kind of change that obviously you have levers on the NHS, you have levers on social care, but you don't have all those levers? How are we going to get the whole of government on this?
Do you know, that's the easy bit. I'm so glad to hear Liz say that because we were working really closely together on the link between unemployment and ill health. And building on some amazing work we're seeing in places, but we need to see everywhere, like integrating health pathways and employment pathways. The Maudsley in South London, for example, do brilliant work with mental health patients who also look for employment support. And let's be honest, will feel much more safe and much more supported in the safety of the NHS than the relationship they have with the DWP. So that's great. We want to see more of that sort of work taking place. But I find, you know, because I chair the Health Mission Board for the government, and I look around the table at ministers from, I mean, they're bashing down the door to get in. Everyone wanted to be on the Health Mission Board, and everyone arrived saying, this is what we can do to contribute to the health of the nation. This is how we want to deliver the Labour's health mission. So that's the easy bit, to be honest. The cross-government working bit. The hard bit is going to be facing down the opponents of reform and making it clear that we are going to have to take hard choices in order to make sure we've got health and care services that are able to not just meet the challenges of the 21st century, but also to seize the opportunities of this century, particularly in terms of life sciences and medical technology.
Who do you see as those opponents? Who is it that's preventing this?
Guardian, the Daily Mail. They're not just them. No, look, you kind of see it on the left and the right, and you know, I pick the Guardian, the Daily Mail because it's fun, but also I think they do speak for their kind of sentiments of their readers and for parts of public opinion. You know, you get people who will say, actually, I don't know why you're bothering going on about NHS reform. You should just pour more money into it. And if there's one thing the Darcy diagnosis was really clear about, like look at our hospitals, we have poured loads more money and loads more people in, and the productivity is poorer and the outcomes are poorer. Why? Because the Tories didn't do the reform that was needed in health service, and they didn't deliver the big shift out of hospital into the community, better primary care, mental health, community services, social care. They just didn't do that. And so you pour more and more money into a broken system and you waste the money. It's got to be investment and reform. You know, the stuff on smoking, which to be honest is at the I think uncontroversial end. I mean, if people really want to die in a ditch to defend children's right to smoke, good luck. Don't expect us to pay much attention to you. But you know, you get people going, oh, are we in danger of being accused of being nanny state? It's like, get real. Like if you're worried about whether action on smoking is going to be too controversial, how on earth am I going to keep people living well for longer and bend the curve of cost and demand? And like that's the thing about like the hard choices bit and the sort of resistance we've had to hard choices. There's just loads of people who are like, oh, do we have to got those hard choices? Or do we really need to keep on kind of talking about them and taking these sorts of decisions? Well, yes, and if you want to, because otherwise you'll be stuck in this endless cycle of short-termism and sticking plasters, and we end up paying a much heavier price as a country, and haven't we had enough of that? So we are going to make hard choices. We've got a mandate for change, and we're going to deliver.
I'm going to come back in more detail on NHS reform specifically in a minute. I'm bringing Jennifer in to just round off this conversation about the link between health and prosperity and the kind of need for action on health across all of government.
Yeah, thanks. Well, it's probably bi-directional, isn't it? If you're rich, you are healthier, and if you're healthy, you're probably richer. And you just have to look at parts of the country. The geographical spread of health is it's not evenly distributed. So I just spent a week up in the northeast and Blythe, and there it's all plain to see the industrialisation, one issues there, the economy, the unbalanced economy that Torsten Bells talked very eloquently about. We've got drugs, a lot of drugs up there, which is polluting the health of the population. And you've got early deaths in men, particularly 25 to 49, the classic working age, prime of working age population. So as well as the patterns that we both talked about, which are absolutely right, there are some acute issues to be done quite quickly, particularly in some parts of the country that are really quite shocking. That, I think you've heard me say this, Wes, but the early deaths in the 25 to 49 is unusual internationally, with the exception of the United States. So we're in the poor company there. So a lot to be done, and clearly in the work I did in Barnsley on economic inactivity, the biggest issue keeping people out of the workforce is health. That's what they self-report. Second is care. They're having to care for relatives that aren't being cared for. But of the health people, 50% of those have mental health problems, one sort or another. Again, that's where the NHS falls down quite a lot. But the good news is 70% of those people who are economically inactive want a job, want some kind of job. So there's lots to play for. So just a last thing, in terms of, well, what on earth do you do? Given that these dials take quite a long time to turn around, obviously cross-government strategy, as discussed with the mission, there's obviously a lot to be done on Devo, because it's only Blythe that knows about what's going on in Blythe that can address the issues properly. And there's resource allocation issues based on need that we haven't got quite right, as IFS showed. We've got neighbourhood renewal that I think Hilary Armstrong is kicking off, which is another big area, how to support communities, the voluntary sector, to keep people alive, which is what they're doing in these communities when council money runs out. And then there's a whole lot of activity on risk factors, diet, sugar, alcohol, tobacco, all the kinds of things that we mentioned. So it's really joining the dots, getting serious about all of those things, handing down devolution to enable through with guidance, to have some local agency. But understanding this is quite a long-term agenda, but actually some central independent accountability would be useful. Just last point, do you remember, I don't know whether we can talk too much about Blair's Labour, but one of the things they did.
And now.
Do you remember there was a sort of there was a kind of state of Britain analysis that was done after every year or every 2 years? We need something like that, like the Climate Change Commission, an independent audit of, are we getting better with respect to health? Where are the dials turning? And I think that would really help with us and keep our focus up in mission work.
I want to dive now into the NHS reform agenda, because obviously the health system is going to need more money, but we're in a world of constrained resources, and therefore the reform agenda is going to have to do more of the heavy lifting to get the system back on the productivity challenge. How much do you think the levers that, for example, New Labour lent on, I'm thinking here of targets, I'm thinking of choice and competition, how much are those going to do the legwork again this time, and how much are you thinking actually we're going to have to do something radically differently here, and what are those new levers that you'd be looking at to try and drive more productive, better NHS?
So I think we need to deliver on three big shifts, from hospital to community, from analog to digital, and from sickness to prevention. We've got to make sure that the NHS gets to people sooner, diagnoses earlier, treats faster. That's better for patients, better for taxpayers, and the way in which we'll be able to do that and keep people out of hospital and at home being cared for is to reimagine the NHS as a neighbourhood health service as much as a national health service, with more services closer to home, indeed more services in people's homes. And that is about shift of activity and shift of people, sure, but it's also about harnessing the opportunities of breakthroughs we're seeing in medtech in particular. On analog to digital, the bar is very low. I think NHS workforce would be absolutely delighted if I just gave them machines that turned on reliably, and it would take 15 minutes to kick off, and if they didn't need 7 passwords to log into different applications to see one patient. That is how bad things are today. It is also about making sure that we harness the revolution taking place in big data, AI and machine learning to do not just a faster diagnosis and more effective treatment I mentioned, but actually the predictive and preventative care, which is going to be revolutionary in terms of how we think about and how we address our own health and well-being. That revolution is here. Some of it is taking place in this country, and the NHS shouldn't be simply benefiting from it. The NHS should be actively driving it. But to get the NHS to that position is not just about a change of levers and systems or performance targets, it is a change of culture. NHS, the Department of Health and Social Care, they are very sniffy about the private sector. I think they kind of see them as providers and suppliers, and they should instead be seeing them as active partners as part of the team. And thirdly, a shift from sickness to prevention. Yes, there's lots we can do within health and social care, particularly on secondary prevention, but lots of the social determinants of ill health require a genuinely, not just a cross-government approach, but we need to mobilise our whole country, government, business, civil society, and all of us as active citizens playing our part in improving the health and well-being of the nation and closing the alarming gaps we see in healthy life expectancy, not just between rich and poor, but black and white, the gaps between men and women. We've got massive health inequalities in this country. Many of them are, as Jennifer said, class driven, but those health inequalities exist and we've got to tackle them, and that requires a whole society approach.
On prevention within the NHS, I mean, people have talked about shifting care. Secretary of State talks about shifting care from acute to primary and community care for a long time. It hasn't happened. In fact, quite the reverse has happened under the last government. We've seen more people in the acute sector and less workforce dropping in the primary and community. How are you going to be different? How are you going to make that shift happen where everyone else has failed?
Well, firstly, by acknowledging up front, not just the 3 shifts we want to see, but asking, so we're about to start the big engagement exercise on the new 10-year plan. Being upfront about that very question. Like, if we all agree that these are the 3 big shifts that are necessary, why isn't it happening? What's going wrong? And why are we failing to walk the talk? But I've got like the most powerful lever of all, which is money, because although it is in short supply, it is ultimately the thing that I have over the system, because I make choices about where the money goes, how we use financial flows and incentives to change behaviour. And so even before we get to any new money that might come in, I'm already going through the hard yards of asking how the money that's currently being spent on health and social care is being spent, and why we get such poor outcomes for such a vast amount of money. So that's the first step. And then in terms of new resources, subject to the fiscal rules and the sensible choices that our wonderful Chancellor makes at fiscal events like the budget and spending review, I'm asking a really fundamental question at this spending review, knowing that it's going to be tight, which is how, particularly on capital and tech, can we invest linked to reform to bring down the spiraling deficits and overspending that we see in particularly the NHS, which then leads to governments raiding capital and tech budgets to plug the shortfall, thereby creating this vicious circle where, because you cut from capital and tech, you lose control of day-to-day spending. So then you lose control of day-to-day spending, you raid capital and tech again, you've got this vicious circle. We need to turn it into a virtuous circle. And so improving the productivity of the system is going to be a big focus for me ahead of the spending review. And the great thing about being in government is you can talk about things like productivity. Because in opposition, you know, no one will say, what do we want? More effective, productive back office. When do we want it now? Actually, it's really important, and giving the staff tools to do the job is really important. Making sure they're using their time to the benefits of patients is really important. And by the way, like, look at the size of this organisation, look at the size of its budget, and look how central its mission is. Like, we've got to raise our ambition. Like, interacting with the NHS should be, the NHS app should be as joyful as interacting with Netflix. Like, there are more users of the NHS, there are more subscribers to the NHS app. So why is our ambition so low, and why are the bar of expectations through the floor?
Final question from me for you guys, and then I'll bring Jennifer, and then I'll promise you we'll get a chance to ask the rest of your questions. Social care. Obviously, there have been lots of rumours in the press about a cross-party or a kind of an initiative to work out what the solution to social care is under this government. What can we expect in the coming year or so on social care? How will you ensure that we don't leave social care as the Cinderella service as it has been for too long?
Well, I'm delighted to announce that on social care, I'm really clear about two things. One is that there is no addressing the crisis in our NHS without fixing the crisis in social care. Secondly, even if the NHS were in crisis, social care is important in and of itself. And I see myself as much as the Secretary of State for Social Care as the Secretary of State for Health. In fact, I look forward to doing media interviews where they shorthand my job title as the Social Care Secretary rather than the Health Secretary. And that's not criticism of media for once, that's criticism on our politics and the lack of focus and spotlight on social care. So what do we need to do to address a generational challenge where successive governments, Labour, Conservative, Liberal Democrat and SNP have failed? Firstly, in this Parliament, I think our ambition has got to be to stabilise the care sector and make sure it is able to work with the NHS in a more integrated way to deal with the delayed discharge in our hospital and to be there for more people when they need it. But actually, over the course of the next decade, address how this social care system as a national care service will meet the needs of both disabled people who increasingly have more complex disability. Thanks to breakthroughs in medical science and technology, people are now living longer and with conditions that would have previously been fatal, including at birth. So that's a wonderful thing, but it means there is a more complex disabled need that must be met. And for older people too, and I don't know about you, but I don't want to just look back on a life well lived. I want to live life until the very end and keep turning up to Labour conferences and being that's exactly how I'm going to spend my retirement. And in order to do that, we've got to, it's true. In order to do that, we've got to give people the support to have the independence and freedom and dignity. This is a big ambition and an enormous challenge. That's why no one has met it. But one of the things that gives me hope at this side of the election is the Conservatives have been completely unconstructive, except on this issue. The Liberal Democrats have actually shown a real willingness to work with us. And even, dare I say it, Reform have said, look, we really want to work with you on social care. So we're currently thinking about, well, actually, what's the best vehicle, what's the best mechanism to facilitate that? Because the great thing about the NHS is, yes, we had big fights with the BMA and with the Conservatives who voted against the foundation of the NHS 22 times. But broadly speaking, in 1948, we built a national consensus around the National Health Service. I've got the same ambition now to do the same for social care in the 21st century, and that means working in a collaborative way, not being arrogant, we've got a big majority, but actually reaching across the aisle and giving all of our political parties the chance to clean up the mess that all of us have had a hand in creating.
Yeah, I thought Ed Davey's leadership actually during the election on care was pretty
I thought it was the best piece of political communication I saw during the election campaign. Ed talking about his family, and I think it was so wonderfully moving, and I think the Liberal Democrats have done a brilliant job raising the profile of social care during the course of the general election campaign. I also just thought that was one hell of a bucket list he had, all those stunts. And the only time I've ever considered joining the Liberal Democrats was when I saw them on a roller coaster at a theme park during the election campaign and asked here while we were on an abandoned train.
Maybe you and Ed could do the party talks, you know, on a roller coaster somewhere.
Enough love bombing in the Liberal Democrats.
Yeah.
I'll get in trouble with some of my party colleagues who fight in local government where they are vicious.
Jennifer, you've been at the Health Foundation for Nuffield Trust for the King Prize. You've sat in a lot of conference rooms and heard health secretaries say they're going to do these things. Why does it happen? And what advice do you have to us to make sure that these words stand into action?
Thank you for that. Yes, I have sat in over the last 40 years, actually, dare I say it. And you have to ask a lot of this boils down to the question. You've got an enormous industry, national health service, 180 billion, the biggest in Western Europe. How do you get humans to have more oomph in the system? I just put it that way. How do you get it to jump more, to move faster, to progress? And you know, I think there are some answers there from learning from the past. You mentioned New Labour. The first thing is, of course, you need investment. We know that. And there's questions about how much we invest still compared to Netherlands, Germany, France, etc. The second is a vision, and I think Darcy showed you that there is a consensus about what we need to do. We've heard it all before. The third is and this gets very technical, is not the what but the how. And there you do have a set of levers, as Wes said. And there's a lot of technical work to work out which is the right blend of these levers across the system to get the oomph that you want. And I think there are three big areas of care we need to think separately about. One is elective care, where you can use the private sector, you can have a kind of factory sort of lean working. There are different incentives there. There's another big nexus, the growing nexus to cope with the coming morbidity, which is exactly as you say, where it's to do with integration, it's to do with proactive community-based support to prevent ill health and use of hospitals. And the third is specialised care. And those blends need to be different for those kinds of things. The Blair government, the long run analysis of what works in that arena was that competition and choice didn't do very much. It didn't do what it said on the tin. And what it said on the tin is that we will upend the system in order to product to using competition choice. That had some effect, but it didn't have much. So the new thing, apart from targets, financial incentives, regulation, all other levers, the bigger new thing is technology. And I think while technology might not be the hope, it is a significant hope, which is where I agree with TBI on this. And the other thing is, I think, is that given the pandemic, we have got a lot of depressed discretionary effort in the system. So hope, human assets, leadership is also something else that we can pull on. There's a huge opportunity there. So the question is, while we're figuring out all that complicated blend, showing leadership, etc., the question now is, what can we show in the short term in 2 years to give us cover for longer term development that we all know we want and we can probably agree on? So what are the strategic and tactical moves in the short term that can turn on some progress? And I think that's where a lot of the energy should be now.
Thank you, Jennifer. Can I just second the point about leadership? I think we forget that actually the NHS is not one organisation, but hundreds of different organisations, and each one has a leadership team. And if you were a private sector organisation, the first thing we do is talent and leadership, and it's often forgotten. So just shout out that. Right, I'm going to ask, open up to questions. Holly has a microphone. The lady in the yellow just here. There's a microphone coming. If you can say who you are.
Hi, I'm Kimberly Hackett from GP Online. Wes, last week the RCGP made an announcement regarding the PAs. They said they voted to oppose the role of physician associates in general practice after concerns about patient safety. What's your view on this, and do you think PAs have a role to play in general practice?
Yeah, sure.
Hi, Sean Linton, health editor of the Sunday Times. Wes, really interesting hearing you talk about shifting care to the community. We've heard it all before. One question I wanted to ask you though is, do you recognise the challenge you've got with the workforce out there in the community who have to be skilled in to take these new patients who are going to have much higher acuity and complex needs than perhaps they've seen in 15 or 20 years? There are nurses out there who may never have seen those kinds of patients. How do you deal with that?
The gentleman just with a fair brain.
Hi, we're Henry Gregg from National Lung UK. We represent the 1 in 5 people who get a lung condition during their lives. Just building on the IPPR report and comparisons with Europe, we actually have the worst death rate for lung conditions in the whole of Europe, which is pretty shocking because we're not the coldest country and we don't have the most smoking, but obviously hopefully tobacco and vapes will help with that. We actually got PwC to cost it up and it cost the NHS £10 billion, 14 billion in productivity and 170 billion to the wider economy. It's also the biggest contributor to women's pressure, so people in ambulances waiting to get into hospital being taken out and then readmitted. So my question is, if you can get some of the money that you've been asking for, how, I suppose building on Sean's question, how can we channel it into managing those people with conditions so they don't end up in hospital during winter through annual checks, vaccinations, making sure they've got access to treatment, because in that way we can save money, boost the economy and also save lives.
Two more. The lady at the back with the suit, Sarah.
Hi, it's Georgia Banjo from The Economist here. Hi everyone, thank you for this. I guess my question is, was that, you said that your biggest opponents are those who oppose reform. Surely your biggest fight is actually with the Treasury in terms of some of the stuff you were saying about capital. It doesn't cost any money to ban kids smoking, but I guess that's the question is, how are you making that case to invest in health? Thanks.
The lady just next door in the red. And then we'll try and get another round in, so
Thank you. I wanted to ask about statutory sick pay. The UK's rate of SSP is the lowest of any nation in the OECD, just £116 per week. And that's not a rate that anyone can live on, even just for a few weeks. That's not a rate you can get better and get back to work on. It's only a rate that you can get more sick, fall into debt, and have those mental health and stress complications of that. And in the campaign, we're hearing stories of people pushing back cancer treatment, just really difficult stories reaching us. I'm wondering what the panel thinks about the merit of reviewing that rate of statutory sick pay along with the commitments made in the New Deal.
yes. PAs, community workforce, customer, HMT, statutory sick pay. Over to you, Wes.
Yeah. Firstly, to Kimberly's question, and where RCGP is on physician associates. But I think physician associates do have a role to play in a modern NHS, and there are physician associates every day in our country providing great care and making a great contribution, not just to patients, but to their colleagues. Where I think we've had a challenge is that legitimate concerns that are being expressed by doctors, both about substitution and patient safety, they're basically being ignored by the previous government, and in the process have felt gaslit. And that has fueled both quite toxic debate, particularly online, that has led, I think, a lot of physician associates feeling quite demoralised and doctors feeling unheard. And it's now led to a number of parts of the profession, now RCGP, not the only Royal College having this debate, basically saying like, right, that's it, enough, throw the bathwater out and the baby with it. And I think to throw the baby out of the bathwater would be a mistake. I think what we do need to do is take seriously, and we are taking seriously, the concerns that are being raised by the professionals about patient safety, to take seriously anxieties about doctor substitution, and to work through in a thoughtful and considered and evidence-based way how we want to approach this issue. So we are thinking carefully about how to proceed, not dismissing concerns out of hand or burying our head in the sand as the previous government did. But what we're not going to do is throw the baby out with the bathwater. And I think that's where we need to shift the debate. And I hope the questions will come with us on that. To Sean's point on workforce, and it sort of links to Henry's point as well, which is you're right about care in the community and in people's home, and the nature of the multiple comorbidities that people are experiencing, you know, requiring a different complexity of care. Training is really important. I'm really proud of the fact that in terms of workforce mix, we committed not just to increase the number of nurses qualifying, but to double the number of district nurses qualifying. And for social care, my ambition for the workforce is not just to pay people more through fair pay agreements, but to professionalise the social care workforce. I don't think of them as care workers. I think of them as care professionals doing highly skilled, hard work, and we should recognise them and give them that progression. And you know, I think part of that is yes, all the things you said about the relation to lung conditions, more checks, effective vaccination, active management of patients' conditions, but prevention also matters, and that's where we want to reduce the demand and therefore cost. That will make contribution discussions with my friends at the Treasury much easier. I can't believe this characterisation, by the way, of my dear friend, the Chancellor. She is wise, she is joyful, and she's got people everywhere. She's thinking about where to put her money at the moment. Look, I think fundamentally, Rachel and I are aligned on two things. One is the link between a healthy economy and a healthy society. And secondly, I mean, I kind of have this kind of weird role at the moment where I'm sat, where if I'm talking to the Treasury, they think here comes the Health and Social Care Secretary making the case you'd expect a Health and Social Care Secretary to make, but I'm pretty sure there are people in the Department of NHS England who think, oh my God, the Treasury have got one of their own in the Secretary of State's office, because I ask hard questions of the system about value for money, about where it goes, and about how we drive productivity. And not make kind of silly pie in the sky cases of best to say when the Treasury knows they'll make the investment, I won't see any of the savings. So I'm trying to repair a relationship between the Department of Health and Social Care and the Treasury that has existed since the creation of the NHS. That would be hard, but at least Rachel and I are absolutely lockstep on how we do that. Which is why, in relation to the point you raised on statutory sick pay, I totally understand what you're saying. Fiscal decisions are a matter for the Chancellor.
Very disciplined. Jennifer, you want to come on the PA question?
I just want one point to make, and physician's assistant episode recently, I think, is really symbolically important, because that's one thing. In the future, we've got thousands of technologies that are going to rain in on the professions. And while safety is a major concern, there's also with protectionism as well. So I think if we are wanting to have speed up technology inside the health service, in particular those that are taking decisions, or at least our decision support, we have to get so much better about assessing evaluating these things really quickly. Otherwise, we're going to run into multiple the same problems, but 1,000-fold higher.
Okay, let's come around. The lady on the floor just down here. Been waiting.
Thank you so much. Hi, I'm Alice. I'm 18 and I'm from Bite Back. We're a youth activist movement fighting for a fairer and a healthier food system. We're so pleased about the announcements that you've made around junk food advertising and the banning of energy drinks. But these big food companies, they say they don't market to children. Our research has shown that 78% of products with child appealing packaging are unhealthy. I picked up this bar earlier. It's full of misleading health claims, but it's also packed with sugar. In fact, nearly half of a child's daily sugar intake. I was wondering what more the government can do if they really want to create the healthiest generation of children ever. Thank you so much.
Great question. Lady on the front seat.
Yeah, Janet Williams here from Infact. We're a business that deals with women that have taken epilepsy medication in pregnancy. So my question is, we've mentioned prevention all the way through it. And we're concerned that there's not enough emphasis on the amount of women that are taking medications in pregnancy and the problems that causes in later life for the children. At the moment, they said there's as many as 20,000 children affected by valve away. We know that figures could be slightly lower than that. We want to know what's going to be doing for prevention of those children and for redress following the use of court.
Thank you. And the gentleman on the fourth row back? Yeah.
Afternoon, hi, Steve Turner. I'm a consultant paediatrician, president of the College of Paediatrics and Child Health. Following on from the young person theme, healthy children become healthy adults, healthy taxpayers, healthy politicians. So I absolutely behind all of this. I guess my question is that we're finding, in terms of flow of money to local authorities and on to school nurses, health visitors, is a real problem. So my question would be how, amongst all of the other things you're going to be able to solve, are you thinking to approach that? Thanks.
And then the lady just on the same row.
Hi, my name is Jamie. I'm with the Socialist Health Association. And I caught your talk yesterday with Fabian, and thank you for having my question. You talked about money that's going into the NHS and reform. Are we going to look at privatization and the amount of money that's going into private-public contracts? A recent study in Oxford said that 11 billion was handed over to private companies, and alongside a quantitative study said that 600 preventable deaths were linked to further privatization. That includes workers' conditions and rights, as well as just general cleanliness and disease that's spreading. I'm from Cumbria, where a hospital was built under Blair for £87 million. We do not own that hospital, and by 2030, we will have spent £101 million on a hospital that we do not own. So my question to you, Wes, is that when it comes to the NHS, it's not so much that it's just publicly owned and free to point of use, but please correct me if I'm wrong, but it needs to be publicly operated as well. If we're going to look at where money is going, it's not just that it's going into the NHS, it's that it's going into those private contracts.
Thank you. And then the lady in the red hair. And
Thank you, Wes. My dad was a GP for 40 odd years. I'm a counsellor in Salford. My question is, quite a few of my friends that do have parents still living are in their 90s now, and they're in care homes, and they're costing my friends or my friends' parents £60,000 a year. And obviously the money will run out quite soon. So are you thinking of placing a cap on care homes? Thank you.
excellent. Where's a bunch of very interesting questions.
Let me take them in reverse order. On the last point, there were lots of things that I felt angry about when we came in and looked at what we inherited. One of them was I think, active deceit of the Conservative Party in pretending that charging reforms were going to come in October 2025. Because it was just a matter of fact that even if the money was there to implement the deal reforms, they hadn't done the operational preparations to be ready for October 2025. And then to add insult to injury, the money wasn't going to either. I think that was highly deceitful, and it raised the bar of expectations, and then we've had to come in and make a decision that was unpopular, with Andrew Gilmore specifically, who is not a man unable to get on the Stay programme to tell us that he's unhappy, but even more importantly, to families. And I can understand, why people are frustrated, because in Andrew's case, he did a huge amount of really high quality work to come up with a solution to a problem. And lots of families were hoping to see that change happen. So we will have to consider charging reform alongside our other priorities for social care. But I felt really angry that we were put in a position where even if the money was there, the system wasn't ready, the money wasn't there, and they knew that before the elections they were telling us the charging reform was coming. That's not the way to do politics. Janie, on your point about use of the private sector, I take the view that, of course, I think it's better for patients and for the value of taxpayers' money if you are able to provide services not just under the auspices of the NHS, but through the NHS for all patients at all times. But we know that with the state that the NHS is in, that the NHS is not always there for people when they need it. and that lots of people are now voting with their feet and going private, paying to do so, either because they have the means or because they are borrowing the means to go private. And what that has done is create a two-tier healthcare system in this country, where those who can afford it go private and seen faster, and those who can't are left behind. And that does not align with my Labour values that everyone, whatever their background, should receive fast access to healthcare free of the points of use. So whenever you fall ill, you never have to worry about the bill. So I think the right choice, the fair choice, is that where that capacity exists in the private sector, we would pay for people to go private, delivering them faster access to healthcare, but on NHS terms, free at the point of use. And that is what we will do while we rebuild our NHS so that it's always there for people when they need it. On Janet's question, I think you raised a really good challenge there, not just on justice for victims, which we are looking very carefully at, because we recognise the damage that's been done and our responsibilities to those families, but also getting it right the first time. And we should think about how we make sure that women who fall pregnant at that point are given all of the information they need up front about how to have a good pregnancy and to provide the very, very best start in life for their babies. And you're right, that doesn't happen in nearly enough places. And then finally, the questions on children and young people. Steve, I come from local government, public health. When I was deputy leader of Refuge Council, I recognise the damage that was done by the last government. I see local government as partners and part of my team in the Department of Health and Social Care. And I'm absolutely delighted that we've just nicked Tom Reardon from Leeds City Council, where he was a brilliant chief executive, an incredible public service reformer, really understood the links between local government and the NHS and social care, really understood primary and secondary care prevention, and is going to revolutionise with us the whiteboard approach and the top-down system we have. And finally, Alice, I'm so delighted to see you here. I love the campaigning work you guys are doing, and it's so important that your voices are heard in this debate. I can't do this on my own. We need your voices and your campaigning, going out there and making the arguments. And I think you're right that we have to work with the food and drink industry and sometimes challenge the food and drink industry. I do not want to be the fun police. I do not want people to start having to hide their Mars bars or their McDonald's when they see me walking down the street and, you know, closing their curtains when I'm out canvassing in case I look through their window and see what's on the table. You know, everything in moderation is my view. But what you've just identified, I think, is the absolutely lousy approach to marketing that sees unhealthy products marketed as healthy. That is not acceptable. And my general approach to these things is to work with us to do the right thing. And if you can't be trusted, we will have to unfortunately make you do the right thing. We'd rather work in partnership, but there is going to have to be, I think, some challenge there, and you're helping to provide the challenge. So it's great.
I think that's from Sarah. I think we need to go with.
Only because I have to listen to Peter Clark's speech, and I know it would be really boring, and drone on and on. But you know, someone's got to be there to clap his flat lines. So, thank you very much, everyone.